Good evening and welcome to tonight's webinar, exploring the role of community pharmacists in supporting patients with experiencing severe mental illness. My name is Gloria. I'm a mental health program officer at Central and Eastern Sydney PHN. I'm joined tonight by my colleague Christina from the CESPIN events team. I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. I'd also like to extend that respect to any Aboriginal colleagues joining us tonight. Additionally, I'd like to acknowledge any family, carers, or people with lived and living experience of mental health struggles and of suicide. I recognise their valuable contribution and value their courage to share this unique perspective. So just before we get started, I'd like to do a quick bit of housekeeping. So please note tonight's webinar will be recorded and available on CESPIN's YouTube channel within the next couple of days. We have a Q&A box and a chat function tonight. So we would like tonight's webinar to be interactive. So please ask any questions you have on the content of the webinar or on the content of the presentation via the Q&A box. There will also be opportunities to ask questions around specific patient presentations or scenarios that you've experienced that you would like some advice on. So yeah, please just ensure any questions are asked via the Q&A box, and then any comments, feedback, or any thoughts you have are via the chat function. So you can access both of these by hovering over the toolbar at the bottom of your screen. And finally, an evaluation form will pop up on your screen at the end of the webinar. Please complete this to allow us to issue you with a certificate of attendance. And we're also keen to hear about any other CPD topics you would be interested in getting more information on. So we're keen to begin delivering more webinars to community pharmacists. So yeah, please provide any feedback around that in the evaluation form as well. So we have a number of CPD events coming up. As you can see, there are a couple on the screen, and you can find out more information and a range of other events via the QR code on the screen. So if you are looking for mental health supports for a patient you're supporting, CESPIN has a number of avenues to kind of seek this support and advice. So the Medicare Mental Health Centre is based in Canterbury, and it offers free, safe space for somebody to get advice around supports that are available to them. Despite the name, you actually don't need Medicare to access this service, and you can either attend in person or contact the service via the phone number on the slide. We also have a service directory if you would prefer to explore kind of what services are available yourself. So the link to that website is on the bottom of the slide as well. And Health Pathways, both Sydney LHD and Southeastern Sydney LHD, have health pathways that have a wealth of information around health conditions and yeah, treatment options as well. And a copy of the slide will be provided in the post-event email, so you can access the links once that email is sent out in the next couple of days. We've also developed a resource with an overview of kind of CESPIN's key mental health services that we commission. And this will also be provided in the post-event email. So it'll be a snapshot of all the key programs that we commission. So an overview of the programs, as well as information around eligibility criteria and links to kind of the referral pathways. So yeah, you will get that in the next couple of days. And then moving on, I would like to introduce our speaker for tonight, Dr. Zelko Mustak. So Dr. Mustak is a consultant and addiction psychiatrist who completed an MBBS at University of Sydney and a Masters of Addictive Behaviours at Monash University. So Dr. Mustak is a consultant psychiatrist with over 30 years experience in within adolescent and adult psychiatry. His experience is spanned across public, private, and forensic psychiatry, with a particular interest currently in addiction and neurodevelopmental disorders. So he's currently the medical director of Docatella, with responsibility for all aspects of clinical oversight and governance. Thank you very much, Dr. Mustak, and I'll hand over to you. So I'll stop sharing my slides, and I think Anita will take over. We do have some polls as well that we would like just to gather a bit more information about the attendees tonight, and we will share those polls shortly as well.
Oh, hello and welcome everyone. So as you know, I'm Željko Mustak, and we provide a service in this PHN. And I'm really delighted to speak with you about enhancing the role of community pharmacists in providing mental health care. As you know, one of the complaints about mental health is that care is fragmented and unavailable, and pharmacists are uniquely placed. You're accessible, you're trusted, and often the first point of contact for many Australians struggling with mental health well-being. So today we'll explore some strategies. We'll look at some evidence-based models and some real-world programs where pharmacy and mental health intersect successfully. So going through what we would like to have as a takeaway is you have an incredibly unique position that so whenever I or anyone else goes to the pharmacy to get a medication, you have an interaction with that person, and that's an opportunity to not only have the professional interaction regarding handing over the medication, but also to understand that person's situation better. And one of the issues that we have, as you know, with mental health services is that services are not accessible, but pharmacists are incredibly accessible and trusted, and in a position that you can uniquely chart the course for the treatment that someone's going to have for their mental illness. So we want to, if we can tonight, increase the understanding of some common but also severe mental illnesses, because obviously it's the severe mental illnesses which cause the greatest concern. And if you can help with those, you can truly transform people's lives. So we'll talk about the opportunities that you have to support people. Sorry, we're still there. And how to collaborate. So at Docatella, we're very, very enthusiastic about collaborating. I was thrilled when I discovered that there's a pharmacist here in Bondi Junction that's happy to inject medications that we need for patients. And you can imagine how much less stigmatizing and convenient it is that a patient can go there and, for instance, have their depot antipsychotics. As you know, it's been incredibly successful having pharmacists rolling out immunizations, and there's certainly opportunity to increase that type of service in the mental health field. And we'll talk about evidence-based services. Okay, so a question, and maybe you can reply to this in the chat box. Have you received any mental health training? In other words, things like mental health first aid, suicide prevention. Have you done something in those areas? Just a yes or a no, that'd be great. Or the other one here, no, but maybe I will. I'll just give you a moment. Please answer the question because it gives us a much better understanding of where people are at. Oh, there you go. I'll answer yes. Oh, hosts and panelists cannot vote. Okay. Okay, thank you very much. Maybe another minute, another 30 seconds. Okay. Well, there you go. So that's great. And I think that this is an area where pharmacists are going to be not only greatly appreciated, but I think that the health system is moving towards pharmacists contributing in this area. Okay. So why does pharmacist involvement matter? Well, basically because you can make a difference. The frequent contact enables early intervention so that you can change the course of mental illness, because mental illness is a bit like steering an oil tanker. It doesn't change easily, and you need to make the changes in steering early on in order to get to your destination. And that role expansion is going to support continuity of care and destigmatization. And if we have time today, I'm going to talk about some of the overseas experience where this has been incredibly helpful. Okay. Now, this is a question too that I think is really relevant. Do you currently refer people to mental health resources? Again, it'd be great if you could answer this question. And it's not designed to make anyone uncomfortable, but it's just so that we can understand, what happens currently amongst our pharmaceutical colleagues and their interaction with mental health services. Well, I'm pretty amazed because I'm getting frequently everywhere. Okay, I don't know if that's the way it is. Do we have a outcome for this?
There's no poll for this one, but definitely looking like occasionally and frequently
Thank you so
winning.
much. Yeah, well, that's great. Okay, so let's talk about what are the opportunities for mental health care that the pharmacist can really contribute towards. So, number one, adherence. And, when it comes to serious mental illness, the number one problem is adherence. And we'll talk about that more going forward and how you can help with that. Of course, side effect management. And I know that now there's the proposal to have a course so the pharmacists can develop greater knowledge of pharmacology and hopefully psychopharmacology, because I think that that's a key role that the pharmacist can play. Screening tools. I've noticed my local pharmacy where I go, they have some screening tools that people can access at the table there. And I think they're really great. And the thing about that is that they can be really brief. For instance, there's a two-question one for depression. Do you have a low mood? Some, many, most days of the week? And are you not enjoying things? Do you have a lack of enjoyment? Some, most, or all of the time? And those two screening questions can be enough. These questionnaires with 9 and 7 questions might be a bit over the top. You can really get the answer to that, and you can even include that in a conversation. And then psychosocial support and referrals. I don't know how many people have seen, but loneliness is a major problem for people with serious mental illness. It's a serious problem for the community at large. And there's a lot of evidence that loneliness results in poor both mental and physical health outcomes. And of course, if you have the opportunity to deal with somebody who's in a crisis and to be able to provide a warm referral, by a warm referral, we mean where you actually make arrangements for them to go somewhere, talk to somebody, arrange the interview or the appointment so that they actually get there. We'll talk about each of those in more detail in a moment. Next slide, please. I was asked to provide some information regarding how common mental health illnesses are. And so here they are. This is a 12-month prevalence. And it's important to know the age of onset. So as you know, a lot of people in adolescence are already experiencing anxiety and depression, which can be quite debilitating. And as you can see that each of these disorders have a time of onset. And interestingly, most mental illness has a time of onset which is early. So it's youth and young people that experience the burden of mental illness. Other disorders, so as you know, ADHD is now something that people are wanting to have treated. And the reason for that is because it's such an effective treatment and makes such a difference to people's lives. And it's not actually included there, but it should be. There's been a dramatic increase in the rate of diagnosis of autism. Some of course, is driven by the need to be diagnosed to get NDIS support, but also a lot of it is just that it's now being recognized, whereas previously it wasn't. I was asked to make a brief comment about the community mental health team because you may need to make a warm referral to them in the situation where you find yourself that a patient's come along and is in crisis. And this is just a brief description of what it consists of. So a community mental health team is funded by the state government, and the idea of it is that it provides support for people with severe mental illness. So often people, when they're discharged from hospital, will enter the system, and also people who are unwell and need to be on community mental health orders. In other words, they don't have the insight to adhere to treatment, and so treatment is mandated for them for a period of time. And again, because of the overwhelming need, when I was a youngster, we used to be able to actually go out and see people. Nowadays, it's more that they make phone calls and then they only visit the person if it's required, just because there's such a demand. And it's interesting that it's such a difficulty that they will very often refer on because they have to make room for new referrals. And what do? They'll provide an assessment, they'll coordinate care, they'll provide treatment, they'll help people in a crisis. And pharmacists and other professionals can certainly refer. If you're concerned about somebody's mental health, there's a number you can call, and you'll speak to a person and you get transferred straight to the area where the person lives. And after the conversation, we've explained what's going on and what the difficulties are. They'll endeavour to help. So it's well worth knowing when somebody needs that intensive support and you're worried about somebody, that's an opportunity to refer, and they'll be happy to hear from you. Okay. I thought that we would talk about some cases, and I think that one of the ones that is really important to talk about, although it's a low frequency illness, is that of schizophrenia. And I suppose a really good question is that that'll be worthwhile asking is, what do you think are the common causes of relapse? So somebody's had an episode of psychosis, they've been to hospital, they've been commenced on treatment. What are the reasons that they're likely to have a poor outcome? And those reasons include, and this is where you can be incredibly effective, is the first one is the lack of efficacy of the medication. So someone can be on a medication and it can be working well, but then stop working, or the dose has been adjusted, and as a consequence of that, they become unwell. This is where if we have a more integrated system, a more collaborative system, you would be able to pass that information to the prescriber and say, look, Joe isn't looking so well anymore. Something isn't going well. The other reason is where, again, you can have a tremendous impact is adherence. The other reason that people don't do well is that they don't take the medication. A really good question for you to ask is, how many times during the week have you forgotten to take the medication? Because by asking the question in that format, you're normalizing that they don't take it. You're not being implicitly critical. Your expectation is that there are times when they don't take it. The other thing that you can ask about is their drugs. In other words, what else are they using that isn't prescribed that can be impacting on their illness? Are they using alcohol? Are they using drugs, cannabis, stimulants of whatever description? What else are they taking? And of course, an issue with people on antipsychotic medications, as you know, is that a large number of the medications do increase appetite and people gain weight, and that can be a reason for non-adherence. And of course, their lives can be stressful. If you're suffering from a serious mental illness and you're unemployed and you're in financial difficulty, that can be stressful in itself. And finally, there can be environmental changes. So why is it important that you are involved in this? Why does it matter? The reason it matters, and maybe it'd be worthwhile getting people to ask, if there's a relapse and somebody has a psychotic illness, does that impact on their prognosis? In other words, let's say they don't adhere to the medication and they become unwell. Does the medication work just as well when it's reinstituted? Can we have a yes or a no and see what people think? Okay, we've got a fair number of no's. No yeses? Okay, so this is the story, and it's really important to know this. So here we have somebody, and on one axis, you have the level of functioning. I don't know if you can, that's the axis going up. And the axis going across is the age of the patient. And this is what happens. You have a prodrome where the person starts to have some symptoms of psychosis. Then you have the first episode. There's a marked decline in functioning. With each subsequent episode, the degree of improvement that is achieved is lowered. And that's because there's actually loss of brain matter. There's actually loss of brain tissue. And the trouble is that once you've had maybe as few as 3 or 4 episodes, sometimes it's even after only a couple, you end up with a chronic relapsing residual form of schizophrenia, which also is resistant to treatment. So the medications which were effective before, which produced a good outcome, no longer do that. So this is something that emphasizes the incredible importance of timely intervention, of intervention that occurs at a time that is going to make a difference. Because once we get into the chronic part of the illness, where there's been a number of relapses, the outcome of treatment is not going to be good. And now the next question is, how many people relapse? So let's have a guess. What proportion of people do you think are going to relapse within 5 years with a psychotic illness, with schizophrenia? Can I get a figure? 10%, 20%, 50%, 80%? Okay, well, you're right on the ball. Yeah, so about 80% of first episode patients are going to suffer a relapse within 5 years. And the most important reason for a relapse is non-adherence, which is again we're coming back to how critical the role of the pharmacist can be, because you can see that a person might be deteriorating, or their carer or family member might mention it to you, or you might notice that they're not coming for the medication when they should be coming. So non-adherence is the greatest predictor of relapse in people with a recent onset of schizophrenia. And even a small period of non-adherence makes a difference, even a small period. So it's not as if they have to not take the medication for months to have the relapse. Even a period of a few weeks can be sufficient to induce a relapse. And this is, again, another possibility for the pharmacist to make an incredible difference to the outcome of people who have experienced schizophrenia. One of the things that I try to do is that there's a much better outcome if people are on injectables, if people are having depot medication. You think about it, you're a young person, because you remember that schizophrenia is an illness of young people. And you're doing well on medication, but you want to go and have a sleepover somewhere, or you leave home and you're going somewhere else. Do you want to take your antipsychotic medication with you and have the situation where you're explaining that you need to take it so that you don't become very unwell again? You probably don't. One of the most effective remarks that I found I can make to young people is to say, look, you probably don't want to have new friendships affected by your illness. Why don't you take away the worry of taking the oral medication every day and have an injection? Now, imagine what a meeting of needs this would be. First of all, that the person thinks, hey, yeah, I don't have to keep remembering to take these tablets, bring them with me, worry when I lose them, and so on and so forth. And I've got the convenience of going to the pharmacist, where there's much reduced stigma. And whilst the other patients are having their COVID or influenza injections or whatever else they're having, I'll just say hello to my friendly pharmacist and have my depot injection. I think that's an incredible opportunity to deliver a service which is going to benefit the person. And the longer that they remain on the depot medication, and the safer they therefore are from having a relapse, you have then transformed their lives, because the future course of their mental illness is changed. So that's just an incredible opportunity that we have to help people, and that we can help by having a collaborative approach with our pharmacy colleagues. Next slide, please. One of the things that we're also asked to comment on is cigarette smoking. Just out of curiosity, how common do you think it is for people to smoke tobacco if they have an illness such as schizophrenia? Can we have a percentage? Just have a guess. I mean, there's no embarrassment if you get it wrong. How common is it? Okay, well, look, obviously you guys know it. You knew what I was going to talk about this evening. You're absolutely right. It's very high. It's close to 100%. If you see somebody who has schizophrenia and doesn't smoke, it's incredibly surprising. It really is surprising. Okay, so let's talk a bit about this. and why this is relevant to clozapine. So as you know, clozapine is the only antipsychotic which is more effective than any of the others. So one of the criticisms that, and again, this is where your knowledge can really make a difference. One of the situations that happens for patients suffering from schizophrenia is that, as we discussed before, if they don't adhere to treatment, they can become resistant to treatment. And then the only medication that can make a difference is clozapine. I used to work in a prison, and in that prison setting, there were people who'd obviously committed crimes and were mentally unwell. And there was one chap who was a very tall guy, I still remember him, and he would stand in the day room where there was a TV hanging from the ceiling, and there was only interference on the TV, and he would argue with that TV for 8 hours. It was out there for 8 hours, and he would just stand there and argue with it. It was quite frightening. And he was commenced on clozapine, and next I saw him in the prison, and he was normal. He was as normal as you or I. You couldn't tell that this gentleman ever had any type of psychotic illness, and that's the difference that clozapine made. Now, again, because I think that a picture paints a scene that you'll remember. My job used to be, I had the wonderful task of seeing people in the prison. And in those days in the prison, the prisoners were allowed to smoke tobacco. So I'd see them in the prison, and we would start them on clozapine. And then if they didn't respond, they would then have to go to the gazetted unit, which was an involuntary treatment place, which was away from the prison where they were not allowed to smoke. And guess what? We had drama because clozapine is dramatically affected by nicotine, by tobacco smoke. So what tobacco smoke does is that it creates this terrible pollution in the patient's body. And the liver says, I've got to do something about it. And this particular isoenzyme increases to chop up the toxins that are associated with tobacco smoke, and then the clozapine level falls. So we would have to adjust the dosage, often by 50%, depending which way they were going. If they were going to smoke, then we needed to increase the clozapine dosage. If, on the other hand, they were going into a situation where they were not able to smoke, we had to reduce it. So that way, it'll be hopefully much easier for you to remember this, that it's really important to be aware that clozapine is primarily metabolized by that liver enzyme, and the nicotine from the cigarette smoke induces that CYP1A2, and this increases the metabolism of the clozapine, lowering its serum levels. Electronic cigarettes and nicotine patches do not induce the enzyme. So you don't have to worry about this if people are using the vapes or using the patches. Now, so abrupt smoking cessation or resuming heavy smoking obviously is something that we need to be mindful of, and something, again, that's really important for you to ask about this, because if the dose of the clozapine increases dramatically, you can have sedation, seizures, hypotension, and a delirium. It can be really quite severe. So if that happens, if somebody comes in and they're delirious, it could be entirely due to that change in the clozapine level. And on the other hand, if they restart smoking, it can cause their clozapine levels to plummet, and then they'll have a relapse. The clozapine becomes ineffective. So if a patient starts smoking again, a gradual dose increase is called for. So again, you're in the best position to know that this is happening and to make arrangements for the prescriber to be informed and to make those changes. And hopefully, in the not too distant future, we're going to have such a collaborative care approach that doctors and pharmacists will share their medical records and what's going on, and the pharmacist will be able to adjust the dosage in keeping with a protocol so that this can be done in real time rather than the delay that currently is required. And that way we can also prevent the subtherapeutic doses or relapse. So what do we need to do? If you do have a patient who's on clozapine, you need to discuss their smoking status at every visit, not just one, or the first or another, and ensure the communication with the care team when that changes, and educate the patient and carers about the risks of both abrupt cessation or resumption if they're on clozapine. Clozapine is most affected. Many other drugs are affected by smoking, but that's the one that really is dramatically affected. And that's why I think it's really important that you have that conversation with people that you dispense clozapine to. Next slide. Okay, so, oops. So here's a very common scenario. So you see a lady, say Sarah, 42-year-old, she's taking sertraline, which is to some degree effective, and she uses alcohol to wind down. Now, what would be really useful to think about here is what happens with alcohol? What does it do? How is it going to affect her being on an SSRI? And what brief interventions and what services can you refer Sarah to get some help with this? I guess the first question is, what happens when you drink alcohol and you're depressed? Can we have some thoughts on that? Can people perhaps put a little answer in there? Yeah, alcohol is certainly sedating, and you're absolutely right. Anyone who drinks knows that the next day they feel more anxious and more depressed. So the brain is like a debit card. So whatever good feelings you get from drinking alcohol now, there has to be the expenditure has to be returned. So people suffer the next day by being more depressed and more anxious. Also, of course, it causes poor concentration, impaired motor coordination, more risk of falls, and so on. So if you see somebody who's older and poorly coordinated, or perhaps somebody who's already got some cerebellar damage, you're more likely to have those sorts of problems. And we talked about reduced antidepressant efficacy. Alcohol interferes with serotonin and other pathways. And also adherence issues. It comes back always to adherence. How likely is the person to be taking their antidepressant if they're drinking? Reduced. And the other thing to mention to patients is the medical effect. As you know, both SSRIs and alcohol affect platelet function. So you have greater risk of gastrointestinal bleeding, especially if it's combined with non-steroidal anti-inflammatory drugs or people on steroids. So it's a really good thing to, somebody comes along, they've got the SSRIs, they tell you they're feeling that they can't sleep, they're drinking, and they've got some sort of aches that they're taking the non-steroidal anti-inflammatories for a problem. And of course, you have the heightened impulsivity. So with alcohol, we all say or do things that we normally wouldn't. So there's a heightened risk of suicide, self-harm, and so on in those people who are vulnerable. And people often self-medicate with alcohol for anxiety or insomnia. So again, there's a tremendous opportunity here to talk about other things that can be done for that. A classic one that I ask every adolescent is their sleep hygiene, because almost invariably it's poor. And I know that there are pamphlets now at pharmacies talking about sleep hygiene. But I think, again, that this is an opportunity for you to provide an incredible amount of information that's going to be transformative. Because if they don't go to sleep 9:30 or 10 or somewhere around there, their sleep architecture is going to be disrupted. And they're not going to have the deep sleep that's restorative and enables them to feel better the next day. And it's incredible how many people take their gadgets to bed, or they're playing computer games or watching horror movies or whatever. And again, that's going to make a tremendous difference. Taking a sleep history is something which is long, but certainly having that brief discussion. It's been shown that, for instance, if a GP says to a patient, I'm a bit concerned about your smoking, that even if that's said in that 2-second discussion, that can have an impact on the person and their future behaviors. So it's really important to talk about it. And how do you talk about it? Ask gently, things like, do you have any alcoholic drinks during the week? Normalize the discussion. Talk about the alcohol in relationship to medication effectiveness and safety. Again, it's really important to say drinking is something that's common. It's not unusual. When you're feeling tense, you're having difficulty sleeping, of course, it seems like a good decision, but perhaps there are better ways of dealing with it. And you can advise moderation or abstinence, and you can certainly refer to support. A really good service that the state governments fund all around Australia is an organisation called Smart Recovery. It's run by people who've had an addiction problem themselves, so they're not going to look down on anyone. But what's even better about it is that if a person is unmotivated, they can do it online. They don't even have to attend a face-to-face group. You can do it all online like we are tonight. And what's really helpful is that you can show them the site. So if you have a laptop there, turn it around and show them the site, and that can be really, really helpful as well. So alcohol use and antidepressants, they go together. Alcohol reduces anxiety, improves mood temporarily, but it damages the effect that the antidepressants or other things can do. And one of the other things to mention is behavioral activation. Again, this is an opportunity for you to talk to people and say, hey, what do you do for exercise? How's your social life? All of those things are going to impact on your mood. Even if you don't feel like socializing, if you go out and socialize, you're going to enjoy it to some degree, 4, 5 out of 10, even if the people you meet might be irritating to some degree. And exercise, it's the key. So in the guidelines, the mood guidelines that the College of Psychiatry has, they talk about those things. So lifestyle things, things like having a social network, having a purpose, exercise. Exercise is as good as an antidepressant, but it needs to be vigorous. It's incredible how many people I'll ask, how much exercise do you do? And you'll have an 18-year-old saying, I take the dog for a walk. Well, look, that's great when you're 80, but not when you're 18. And I joke with them about it and say, look, if you were 80, I'd be impressed, but not at 18. You can do a lot more than that. Okay, next slide. So what about illicit substances and mental illness? So Barry's 35, he's been diagnosed with anxiety and depression, and guess what he's discovered? Cannabis or prescribed cannabis. So let's think about this. Now, what sort of effect is that going to have? And what's it going to do in terms of his anxiety and depression? And as you all know, if you have that discussion with people, I always joke with patients and I say to them, look, Australia's conducted an incredibly interesting experiment. People have used cannabis on a vast scale. And as far as I can tell, the mental health of the country has not improved. So maybe we should give up on that. Maybe that's not the way to go now. And people will reluctantly acknowledge it. They'll say, yes, you're right. I remind people that the old name for cannabis was dope because it makes you dopey, which, in my day meant you're amotivated, you don't feel like you want to do much, you haven't got much to say, and you're not much interested in doing anything. And of course, that's the exact opposite of behavioral activation, which is one of the key interventions, especially in young people with depression. And just to also, again, this is an incredible opportunity. You might have mum or dad come along with their teenager saying, Mary's using substances and like cannabis, and you can remind them. You can say that, look, there's a risk of psychosis. Do you know that daily cannabis use can increase the risk of schizophrenia by 2 to 5 times if you're doing that in adolescence? That's the case. For a long time, we debated it. We know that we don't need to debate it anymore. That is the case. If you're genetically vulnerable to it, you can have a really bad outcome. And similarly, if, Mary or Joe or whatever's on an antidepressant and are taking cannabis, guess what? It's not going to work very well. I mean, the antidepressant. How are we going for time? Sorry. What time am I meant to stop?
It's about 7:45, so maybe around 8 we might look if there's any questions.
Okay, perfect. Thank you so much.
Thank you.
Another case that I think you're going to come across fairly often, because I do. So nowadays, I'm almost exclusively dealing with people with ADHD and autism. That's because there's such a demand for it now. And what about ADHD medications and misuse of substances? What happens there? So Liam, 19, is being considered for dexamphetamine for ADHD. He occasionally uses cocaine, refuses urine drug screen. What are the risks of stimulant prescribing in this context? So can you tell me what's the rate of psychosis with stimulant prescribing? Does anyone know what sort of percentage rate is there? Just if we don't have any substances, but just if we're just using the stimulant, the prescribed stimulant. Does anyone know? You can have a guess. I mean, just give me a figure. Low. Well, not very low. Yeah. 50, 60%. Yeah. 20, 5, 10, 30. Okay, great. So look, the story is that there's a difference. And now this is still controversial, but I think the evidence is really clear. With Ritalin or methylphenidate, it's about 1%. With dexamphetamine, it's about 2%. It's still very, very low, but it's there. And so, as you know, in children, adolescents, Ritalin produces much fewer side effects. So if you go to any primary school, you'll find that 98% of people of the children who are being treated for ADHD are on Ritalin, a small number on dexamphetamine or Vyvanse, because it does interfere with appetite more, sleep disturbance, and so on. But, and this is the problem, when you have people with attention deficit disorder, guess what else you know? You know that they're novelty seekers. They need excitement. They get bored easily. So they're inclined. So whereas somebody who's cautious and nervous about things will say, oh, no, I'm not going to take that pill, or I'm not going to smoke the joint or whatever. These people, hey, yeah, what a great idea. Let's go for it. Fantastic. So people with ADHD, we need them in terms of evolution. They're the people who are willing to take a risk. They're willing to leave our cave and go look and see if there's a tiger out the front, whereas the rest of us are quivering in the back. But on the other hand, that type of risk in our society can often result in bad outcomes. So there's a much higher rate of substance use with patients suffering from ADHD. So the risk is if he is using cocaine or MDMA or whatever, that they also have a rate of psychosis. And then you have both the rate of psychosis that's associated with the ADHD medication and that associated with the substance use. And another question to ask, which is one that's really, really useful, is if you ask somebody, let's say they come in and they say, hey, I use cannabis and it calms me down. A really good motivational interviewing technique to ask is to say, hey, I hear that. So the cannabis calms you down and you feel better for it. Does it have any negative side effects? Is there anything that's a problem for you with it? And they might say, oh, yeah, well, sometimes I get a bit paranoid afterwards. Sometimes it doesn't happen very often, but I'm noticing that lately I'm getting paranoid a little bit more often with it. Or I had a panic attack when I took it. And normally I'm not suffering from bad anxiety and so on. And this is an incredible opportunity again for you as the pharmacist to say, hey, maybe that's not a good idea. Have you thought about that this might be detrimental to your mental health, that you might pay a price for it? And the reason that the substance use is so important is because sometimes people become psychotic and they remain psychotic. It's rare, it's not common, but if it does happen, it can be a major problem. So how would you discuss safety and treatment eligibility? So again, you can say to people, if you're out to get treatment for ADHD, you're not able to do your homework, you can't do your assignments, or if it's a 19-year-old and he's struggling to do his TAFE, he's not able to keep up with the work that's required at technical college, that's a really good opportunity to say, hey, if you stop using the cannabis, you can get onto stimulants and similarly the other drugs, and then you can concentrate better. You'll be able to pay attention to things that are boring, that don't interest you. You'll stop making errors that are preventable and that you make by carelessness. And even you'll stop being impulsive. You'll stop making decisions that you might later regret. So there's that incredible opportunity to have that discussion and to have it casually, but always in a non-judgmental fashion. To say, it's just, I'd like to help you. Have you thought about this? What about that? Do you know that if you're going to go for stimulant prescribing, you've got to be able to do a urine drug screen, that kind of thing. Next slide. I think we better move along a little bit. So how to expand your role in stepped care. So this is a trick question, and I'll ask you to say yes or no. Do you think the mental health of Australia has improved since the 1990s? Yes or no? Now, remember, there's been a lot of dramatic scientific discoveries, lots of new medications and treatments, and yep. And the no's win it. Yeah, it hasn't improved. So what needs to happen? So care needs to become more available. And one of the wonderful things is, and I think that the governments around Australia are recognising that pharmacists are an underutilised resource. You can really make a tremendous difference. Obviously, I'm focused on the mental health area, but similarly, one of the things that you can do is that somebody might be, for example, taking a antipsychotic medication that's causing them to gain weight. Again, you have a tremendous opportunity to intervene there. One of the things that now with these new medications, you can really make a difference. Whether it's Wegovy or one of the others, Manjaro. I had a lady who lost 22 kilograms in 2 months. So what previously required bariatric surgery can now be done medically. But, you need to say to people, hey, you've put on a bit of weight. It sounds like the antipsychotic medication is really doing you good. It's really improved your quality of life, but you have these physical things. Have you thought about asking your doctor about this? So it's exercise and dieting, they're all great, but as you know, incredibly ineffective. They're not effective. And, we now have a game changer in terms of these medications. Okay, so expanding your role in stepped care. Level 1, health info, digital signposting, saying, hey, if it's somebody who, as we talked about, has an addiction problem, maybe smart recovery. There's many wonderful digital health sites that the federal government's funded. There's one called This Way Up, which is run by St. Vincent's Hospital Anxiety Clinic. If you have somebody who's got OCD or anxiety or panic attacks, depression, whatever, sleep problems, want to improve their sleep hygiene, whatever it is. And a trick of the trade is when you recommend it to somebody, always ask them to do it with somebody else. It's like gym membership. You can get gym membership and you don't go. But if you've got a personal trainer, you have to go there and actually you'll go and do it. So when you prescribe this program to a person, what happens is that you put their name in and your name, and you can actually check how many of the modules they've done. When I did that, I was shocked to find there's generally 6 or 8 modules that 90% of people stopped before the final module. They didn't do it, even though they spent money, they came to see a psychiatrist and all the rest of it. But when I recommended they do it, their husband, wife, daughter, friend, whatever it is, guess what? It dramatically increased, a dramatic increase. So always going to do it with someone else. Level 2, structured adherence to programs. Level 3. So look, these are the opportunities for you to do things, and we're really hoping that by talking to you tonight, that we at Dr. Teller and us psychiatrists can work more closely with pharmacists and with organizations like the PHN, because ultimately we really need to be able to share our notes and be able to work as a team to deliver the outcome that patients need. Next slide, please. Okay, so this is a question for you. Please think about it. Which of these would you like to expand your practice after hearing about the opportunity that you have to make a difference to people's lives? Which of those do you think? You can put 1, 2, 3, or 4. Oh, okay, fantastic. Digital. Yeah. Okay. Have we got any scores? Fantastic. Fantastic. And look, if you help patients with adherence and brief interventions and risk referrals and the digital health signposting, my goodness, this could make a tremendous difference to the community. A tremendous difference. Okay, next one. Next slide, please, because I've only got a minute left. So look, we obviously haven't talked about these things. There's another 15 or 20 slides that I was hoping to get through, but obviously I've been too verbose again. But these are the things that we would really like to work with you. The answer to helping the population with their mental health is us working as a team. And the real issue is that a lot of what we do needs to go to the place where patients attend regularly, informally, are available for interaction rather than. So look, what tends to happen is the fault is really with us doctors and psychiatrists and psychologists and so on, because we're all terrified that we're going to be out of a job because obviously we know how incredibly useless we are. So as a consequence, what we don't do is pass on responsibility to people like yourselves who can really deliver a service. So I'm hoping that by having this discussion this evening, that we can all reflect on this and perhaps work in a much more collaborative fashion. And now it's 8 o'clock and I better stop for questions.
Thank you. That's been really interesting. We do have 2 questions so far in the Q&A box. If anybody else does have questions, please pop them into the Q&A box. If you have any questions on the content of the presentation, but also if you want this opportunity to ask any questions around any particular patients that you're supporting, or a scenario that you've dealt with in the past, and maybe some advice on how you would kind of approach it in the future. But if there's no more questions that come in, we can go back to the presentation
Oh,
because I do have
perfect.
a
I
lot
can keep
more.
talking. Oh, wonderful.
Yeah. So I just thought I'll give the opportunity for people to pop questions in now, but we do have 3 questions. So the first question, um, is, yeah, when a smoking status changes, kind of how to approach that. Are you better to slowly taper up or down the clozapine dose, or make a kind of significant change to the dosage straight away?
So I think it's really important to see where you are. What I mean is that obviously you have to ask how much are they smoking? Is it that they had one cigarette and they're feeling bad about it and they're not going to continue, or have they resumed smoking 20 cigarettes or 40 cigarettes a day or whatever it might be. So you need to get that sort of information. But what our practice was, so remember, my role was as a psychiatrist, both to be in the prison, so I'd be seeing people who are able to smoke, and in the locked gazetted unit where we treated them. And what we would do is that we would change the dose by 50% depending on where they go. That was our practice. But that was because when they went from one to the other, they were chain smokers. So they would go from no smoking to 40 cigarettes or 40 cigarettes to none. Yeah. Now, it might be 30% might be appropriate. You might want to do it over a week or 2 weeks. It really is a matter of judgment. There's no formula for it, but you need to be really careful with it and get a good history. But as I say, people with schizophrenia are very, very high nicotine addiction problem. So it tends to be a really they don't usually smoke one cigarette.
Well, thanks for that. The next question was just around the digital health signposting, and if you could kind of explain a little bit more about what that actually involves, or what
So
it is.
yeah, so look, there's a tremendous number of resources, and um, I'll just talk about the ones that I tend to use. So if you um, um, have somebody with a mental health problem. So I'm seeing somebody and they say they got depression, anxiety, whatever. You can use any one of them. So for instance, MindSpot is one, Mood Gym's another one. I've already mentioned the This Way Up. And they each have their advantages and disadvantages. And if you talk to them, because every now and then they come and present, they there are two things to really say about it. The first thing is that they all claim to be incredibly effective. So they'll claim that they, for instance, get a 50% improvement. I don't think that that's quite true. I think it's exaggerated, but I do think that it's really important to nevertheless use them because they're just amazingly helpful. To a degree that medication can't do everything. But very often, for example, if you have somebody with anxiety or depression, you really want to encourage them to also try the medications because often the psychosocial intervention is not going to be enough. Now, remember, I'm seeing people who've seen a GP and where the treatment hasn't been successful. Obviously, with people with a lesser degree of severity, it's quite different. And you can go to places like Black Dog and all of those, and you'll see all sorts of courses, for example. You can go to Black Dog, and they've got a thing of 7 days online social anxiety treatment, all sorts of things, digital mindfulness projects, all sorts of things, how to overcome worrying. There's so many of them that it's endless. And if you use your phone and download ones, there's things like I think it's Saturday Morning or something like that, which is for alcohol. So to encourage people not to drink. So you can put that on your phone and it'll remind you that there's so many of them out there. And you just need to encourage people to pick one for their particular, or pick two for their particular indications. But the really hard thing, as I say, is actually completing the modules and actually doing it. And that's where the key, I think, is to do it with somebody else. It doesn't really matter which one you do, but the key is to do it with someone else.
Mhm. Yeah, thank you for that. And I've been trying to keep track of the different services you've referred to, so I will include a link to all of those services in the post-event email as well, because I know we've had a few questions around just what was the name or for further details. So we will include those in the post event email. The next question was. And I guess there's actually two questions that have come in which are quite similar. So one was around how to kind of approach that topic of illicit substances without causing offense. Um, and yeah, actually maybe we'll go with that question first. The other question is a little bit different.
Okay. So look, with regards, I always ask people, what substances do you use? Because almost inevitably or invariably, people will then tell me things which otherwise wouldn't have come up. So I normalize it and make sure that people feel comfortable to tell me about it. And if they say something I don't, I say, really? You haven't used any substances? I'm amazed. So as to encourage them to again, and then people say, well, yeah, look, I stopped 2 years ago. I used to be a daily cannabis user, or, I'd use MDMA or whatever it is. So you need to normalize it first. And then the next question to ask is, what does it do for you? Because you really need to understand what it is that encourages them to use it. So, for example, you might have somebody who's on the spectrum who's a little autistic. And for them, they're socially awkward. They find it hard to fit in. Well, guess what? You use some MDMA or whatever it might be, and suddenly you're dancing as crazily as the next person. And it's all good. You're normal. You fit in. You belong. Or you're somebody with terrible social anxiety. And guess what? After the fourth or the fifth glass of wine, you're relaxed. In fact, you're chatting away. You really think you're the most interesting person in the room, whereas normally you can't get a sentence out. So when you ask people, what does it do for you? You actually get an answer that enables you to then be able to understand what their issues are and then to approach that. So, if it's social anxiety or whatever. Um, and I've forgotten the website now, but there's another website for young people. It's called Reach Out, which has, maybe, I don't know, maybe 40 telephone apps on it. And it has, I don't know, 30, and they're all free. They do come in different variations where, but again, they can get educated on things there. They can get educated on drugs. So the key questions are, number one, that humans since time immemorial have done things to alter their brains, because our brains are meant to be rewarded by company, by achievement, by sex, by food. But isn't it wonderful that you can drink a glass of wine or whatever it might be, and suddenly your brain feels a lot better? You're cheating. You're cheating evolution, and you're making yourself feel good. So substance use doesn't mean anyone's a horrid human being. And if I do see somebody has quite a severe history of it, I reallocate blame. So I say to them, 60% of the variance, and this is true, of addiction is genetic. In other words, that if your parent or both parents or an uncle or whatever had a terrible problem with addiction, 60% of your risk of having the same issues is related to the genetics. There was a classic study that was done somewhere in Denmark or somewhere, and they had children from families where the parents were admitted to psychiatric hospitals with uncontrolled alcohol addiction. And the children were farmed out to ministers who didn't drink at all, strict Protestant ministers. And guess what? The rate of alcohol abuse or alcohol addiction ended up being very high. The environment made minimal difference to if you have a big genetic contribution. Sorry, that was a long-winded answer.
Mhm. No, thank you. That was really good. Um, and then the next question is just around how to deal with patients who are on opioid withdrawal. Sometimes they are vulnerable.
Well, let's talk first about opioid replacement therapy. Opioid replacement therapy is incredibly safe and effective, so it's just wonderful. So methadone in the old days kept I don't know, hundreds of thousands, millions of people alive that now wouldn't be. So, and remember, methadone is just long-acting heroin. There's nothing special about it. It's just that it's safe because it's long-acting. Now, so the first thing is that I get worried when somebody says, I'm coming off opioid. So when people say, I've done really well, I've been on, nowadays it might be the depot injections or buprenorphine or whatever. I've done incredibly well. And they say, my family are all encouraging me to stop it now. I don't need to keep going. That's when I get concerned, because what's happening then is that they're now entering the high risk phase. It's when they go off their replacement therapy that they're very likely to find that the addiction hasn't gone away, and they end up using, and because they don't have tolerance, they end up overdosing and dying. So the first thing is to get them onto replacement therapy. What's really wonderful nowadays, and where again I think the pharmacists can play a role, is the depots. So, and look, if I say this, there's going to be people who want to again beat me up, but I don't think there's any role for methadone anymore. When I say this, and to addiction specialists, they always want to beat me up. I just think that it's just too dangerous, and you've got the choice now. So yeah, there's the old versions of buprenorphine that are orally ingested, or put in the tongue and so on. But now there's also the depots, which are just transformative, because patients will always tell us, I don't have to stand at the pharmacy and wait till everyone else gets served and feel the stigma that I'm the nuisance in the place, that now I can go into the pharmacy, have my injection and leave like the COVID person or the flu or whatever else has come before me. And we know then that they're safe. It doesn't matter if they inject heroin, the next day, they're safe. We've kept them safe. So the issue with opioid replacement therapy is that I think it's a game changer having the depots. I think the pharmacists, if they would all kindly take up injecting the depot medications, would make a tremendous difference to the lives of people with opioid addiction problems and keep them alive. And look, I think that remember that opioid replacement therapy was prescribed by GPs. I really don't see any reason why pharmacists couldn't do it, both the prescribing and the injecting. It really is an incredibly straightforward and easy treatment process, and would keep a lot of people alive. It's really something that. So remember that the history of this is the GPs who used to do opioid replacement therapy were just GPs who got interested in that and did it. They then got recognition and got Medicare funding, and now they're a specialty in their own right. The trouble is that now there's a lot of patients who can't get access to opioid prescribing, and that's a whole issue in itself, because the GPs who used to do it have retired, or they've specialized and gone off to do other things, and now the patients are left in the lurch. So that's a major issue.
Thank you for that. The next is, I guess, around a barrier for community pharmacists to provide a lot of the support. So the comment is just, would love to do more as a community pharmacist, but with no clear path towards adequate remuneration and lack of time to provide this service. How is it possible?
Look, I think again we can look at what's happening and make a plan. So the first thing is we talked about that pharmacists are an underutilized resource. They're overskilled, I think, for what they do. I think that AI and pharmacy technicians are going to do a lot of the work that pharmacists used to do. And I think that what pharmacists need to do is step up. Now that's happening already. You're seeing that with UTI prescribing and all sorts of other things. But I think in the mental health field, there's a tremendous opportunity for that to happen. And that is happening overseas. It's going to happen here sooner or later. And you're absolutely right. The model needs to be sustainable. So whoever asked that question, you are right, you are right, you are right. It needs to be sustainable. There needs to be funding for it. It needs to happen. But the way I think to do it is like we're talking tonight, that what we do is we work as a team, we work together. So for example, if A pharmacist is seeing somebody and they need their depot opioid replacement, but they're unwell. They might be psychotic or whatever. What do you do? If we work as a team, we can manage that. Maybe they've ingested something, used some illicit substance, they're delirious or whatever's going on. I'll tell you a quick clinical picture of I was working at this addiction hospital. I put a patient on atomoxetine, which is a non-stimulant medication for ADD. Next thing he comes in, he's totally delirious. He doesn't know where he is. He's seeing things. And I think, oh my goodness, what have I done to him with my atomoxetine? Well, what turned out to be the case, he'd gone to his local friendly pharmacy, got a bucket load of Phenergan, taken the whole lot because, of course, why would you take one when you can take 3 bottles or whatever? And he was delirious. Once we knew what was going on, we could manage him appropriately. So having that kind of information, having that kind of interaction would just make all the difference.
Mhm. Well, thank you for that. So we have a couple more, and then we'll see if we have time to go back to a bit more of your presentation. But what is the best way to manage somebody who is disruptive in the pharmacy? Mhm.
Look, this I'm shocked. Look, I know I look 25, and you're going to say, "My goodness, he's so youthful." But I can't believe the cultural changes in this country. I'm going to sound like an old codger now. The amount of rudeness and aggression and violence and so on that's happened in Australia is so. Look, there's lots of good things. There's women's rights. There's women. Now today you go to a medical school, and a majority of people who are doctors are females. So there's a lot of good things that have happened. But I've never been so surprised. I went to a shopping centre the other day, and there was a sign on the coffee shop saying, "If you physically attack us, we will not serve you coffee." Now, that's a sign that we never needed to have. When I was a young pup, that just did not happen. You didn't need to put up a sign like that. I think there's an incredible change in the culture of this country. And look, this gets into a whole bigger psychosocial sphere where entitlement, aggression, demandingness have just escalated. Um, you see that with road rage, you see it everywhere. So it's not limited to the pharmacy. And I think it's a cultural problem. And I don't know that a pharmacy can do anything about it. So when I was working in accident emergency, patients attacking doctors or nurses was a rare phenomenon. We didn't need security guards. Now you do. That's not just alcohol or drug use. It's really the change in culture. If you don't do what I want, if you're not going to provide me with. So on the one hand, there's a lot of talk about people's rights, but much less acceptance of people's responsibilities. So what do you do with somebody who's disruptive? I think there needs to be a cultural change. I think that society is going in a direction where that doesn't happen. So lots of good things have happened, like we don't beat children anymore. Corporal punishment has stopped. Domestic violence is, something that's not, we know how extensive it is. Lots of good things have happened. Not diminishing that. But also there's been this incredible entitlement to aggression. If I say to somebody, like I have, you're smoking cannabis, there's a risk of psychosis, you really need to produce some clean urine drug screens before I can prescribe stimulants for you. The reaction is sometimes extreme aggression. It's not appropriate. I'm not doing this to harm you. So no, I don't have an answer to that. I think it's a cultural, psychosocial issue, and I think we have to look at the way that the society is changing.
Mm. Yeah, no, thanks for that. So then the next one, sorry, I have a few more questions. So if an antipsychotic is causing metabolic changes, would you consider changing the medication
Absolutely.
or,
Absolutely.
oh yeah, okay, because it
Absolutely.
was the second part of that was, would you change the medication or try to indicate weight loss agents?
No, change. So look, let's just be clear. In simple terms, there's 2 big groups of antipsychotics. There's the ones that are sedating and increase appetite. And so, for instance, we'll use Seroquel or olanzapine in the hospital situation, but we really don't want it in the community. So typically when I had inpatients, we'd put people, say, on Seroquel because they need to get to sleep. And then I'd see them in the morning and their faces are covered in chocolate because they got hungry during the night and they ate some chocolate, fell asleep, and they'll put on 2, 3, 4 kilos in a fortnight admission in the hospital. So all the psychiatrists have heard so many times now, we should not be using those drugs, the Serocals, the olanzapines, in people who tend to put on weight with it, which is the vast majority. So the average weight gain with olanzapine over, say, a period of 3 months is 12 kilos. So that's a lot. So we need to get off them. So what I say to patients is you have the choice. You can go on to the medications which are much less likely to induce weight gain. However, they can cause akathisia. And as the pharmacist would know, akathisia is that terrible feeling of restlessness, that awful feeling that when you have it, it's horrid and all you want to do is jump out of your skin. But that's the risk you take. So we have a choice. We either use the drugs that can produce the akathisia but don't produce the degree of weight gain that the other ones do, or the weight. So what happens is you go to hospital, you're unable to sleep, you're agitated, the psychiatrist is inclined to give you a sedating medication. The trouble is that produces the metabolic changes when really we should be thinking down the track. So all the experts are now saying don't give them those, give them the ones that are non-weight increasing, but maybe add some benzodiazepine or something else to produce the sedation that they need. So change the drug, change the drug, change the drug. Once you've done that, a lot of people are able to lose the weight and then advice can work. But for those people who can't, or it's too late, they've gained the weight and they can't lose it, the new drugs are amazing. The Manjaro, or as I say, just amazing.
Yeah, but it's not the first kind
No,
of
no, definitely
approach.
not.
Okay.
Not the-
I'm conscious of the time, but we've 4 questions. Um, so we might try just quickly get through those. But the first one is, what are your thoughts on the Maudsley antidepressant deprescribing guideline?
So look, let's just talk about deprescribing. There's always the articles that come out and say, why don't you go off, you've had an episode of depression, you're better, go off your antidepressants. So what we've learned is that whatever the illness is, whether it's schizophrenia, whether it's bipolar disorder, whether it's depression, whether it's anxiety, where it's actually an illness, where it has a certain degree of severity, that what happens is that the more episodes you have, or the worst episodes you have, the more likely you are to have more episodes. So a statistic is that if you have one episode of depression, that's not where, my girlfriend left me and I lost money on the football betting. That's not depression, but where you have the anhedonia, the lowered mood that's there consistently, the sleep disturbance, the pessimistic outlook, all those things. Let's say you have that. If you go on antidepressants and they have a good response, there's a chance, probably about 20%, that you're going to have a further episode in 5 years. But what happens if you've had 3 episodes? So you've had 3 episodes of depression, 1, and then 2, and then 3. What happens then? Well, it's virtually 100%. It's 100% that you're going to have another episode of depression within 5 years of stopping your medication. But the worst part of it is that the medication can then be ineffective. So let me give you an example. I saw a lady just recently, and she said she'd been on antidepressants for, I don't know, 15 years or something. And before that, she had quite severe depression. It was debilitating. She couldn't get out of bed. She was unwell. And she says, each time I try to get off the antidepressants, it doesn't work. I end up being unhappy. I can't function. I can't go to work. I become irritable with my spouse. And she said, but I'm trying to get off it again. And I said, why are you trying to get off it again? And she said, oh, you shouldn't be on it forever. And I said, why not? So let's just be clear that the antidepressants can really be a blessing. They can really be life-changing. Now, the problem that we come across as psychiatrists quite regularly, and I come across it, and I joke with people, I say, look, when I see somebody like that, is that a severe recurrent depression, which is controlled by the medication, you have a choice. One is to stay on the medication, which is working well for you, or the second one, and look after yourself, or the second one, to go off the medication, have a recurrence of your depression, and then you run the risk that the antidepressant medication that you used before will no longer be effective. It just won't work. And then we have to find another antidepressant that does work for you. Now, maybe we'll find one, but maybe we won't. You might end up with a chronic resistant depression for the rest of your life. Is that really worth it? So then you're going to look after me and you're going to pay my bills while I try and pay off my ridiculous mortgage in Sydney. Or you can look after yourself. Take your antidepressant and stay well. Choice is yours. Whichever. You can be selfless and help me or help yourself, whatever you prefer. So let's just be clear. There's a lot of people who are on an antidepressant and it stops being effective. That's the bigger problem. That they are taking the same antidepressant at the same dose and it just doesn't work anymore. Now, there was a study done many years ago called the STAR-D study. And basically what it found was that if you don't respond to the first or second, the chances of the third or the fourth are not great. And that's really important to bear in mind. So what happens is the more relapses of any illness you have, whether it's schizophrenia disorder or bipolar disorder or depression or whatever, the worse the outcome, the more likely you are to have a treatment-resistant disorder. So that may not be quite answering the question, but the point I want to make is the opposite one, that adherence to medication can make a tremendous difference to people's lives. And one other trick of the trade to mention is a lot of people go off their antidepressants because of sexual side effects. So they won't raise this with you. You've got to raise it with them. So you have to say to them, hey, it's pretty common to have sexual problems on antidepressants. Do you find that? Just make it matter of fact. It's not intruding or asking any questions. And you'll be surprised how often they'll say yes, because I was surprised. I'd see these people who would say, oh, the antidepressant worked really well. And what's happened? Oh, I've stopped taking it. And I thought, well, what's going on? It works so well. Why just stop taking it? And what they didn't want to tell me is the sexual problems. So all the SSRIs, SNRIs can numb people's private parts. And what you do about that is if you're on a short-acting one, say like escitalopram, you just have to make a decision that you're going to have, for instance, sex on a Friday night, and then you don't take your medication Friday morning. That way you give your brain a 36-hour interval from the last dose. That won't cause you to have discontinuation syndrome, but your sexual functioning will probably return to normal. And then you take the medication after sex that night and then again the following morning. That way your total weekly dose is the same. You haven't changed it, but what you've done is you've reduced the likelihood that you're going to have that problem that's going to cause you to not want to adhere to your medication.
Thank you. No, that's really interesting. So we have three left. I might quickly try to get through them. So one is I've seen multiple antipsychotics being used at the same time. So used together, even including clozapine. And how appropriate do you think that is?
So the rule is that with any medication, you try and use one to the maximum. So we all know that, that's the sort of, rule. And again, this is where the pharmacist can have a tremendous impact and say, hey, that's a bit unusual. You're on a bunch of medications. Have you discussed this with your doctor? And have him or her go back to the doctor and say, well, look what's going on here. So let's just be clear. If you use multiple medications, the worry is that you're going to not know which one's effective, which one's causing side effects, and you're in a spaghetti bowl of confusion and you don't know which way to go. So the rule is you start one medication, you increase it to the maximum dose. If it turns out that it's not effective or it's insufficient. So for instance, with antidepressants, we might combine antidepressants because they do work on different receptors and you might have somebody with a treatment-resistant condition that needs it, but it really is a last resort. Now, with clozapine, because it's so much more effective than every other medication, there really shouldn't be I wonder if maybe they're on Seroquel as well because of sleep or something, but clozapine's sedating, so I don't know what the logic of that is. And it's not good practice. And this is again where, with this sort of team approach, patients can get a better outcome. So, pharmacists already monitor, medications and, what might be going on and warn of interactions and so on. I think this would just be another really good opportunity to say, hey, a bit unusual. Would you like to go back to your doctor and ask? Because maybe it's just been forgotten. Especially with elderly people, what tends to happen is medications get added but never removed. So they just add up with more and more medications, but
Yeah.
not reviewed.
No, thanks for that. Okay, so second last one was around a time frame from when somebody stops actively taking heroin to start um then commencing methadone. Like, is there a time frame that there should be between that?
So, as I say, I mean, methadone's not my preferred one, but so methadone, remember, is just long-acting heroin. So it's really easy. It doesn't really matter. I mean, if they're using heroin, they presumably have a very good tolerance to it. You can start them on methadone if that's what you're going to do. But as I say, so methadone has a lot of problems. It dries your mouth out, so you're going to get caries. All your teeth are going to fall out. You're going to get constipated. You're going to have terrible constipation, which is going to be quite debilitating. It causes sexual problems. It causes sedation, and of course, because it is something that is strictly controlled because it is long-acting heroin. You're also going to have the stigma of having to go somewhere and get dosed all the time. It takes a long time before you're trusted to have a few takeaway doses. And it's just a whole pathway that's best avoided. So what I used to do in the good old days before we had the depots is that we would wait for people to go into withdrawals. You have to give it 48 hours and then introduce buprenorphine, Suboxone. And the reason you do that is because if you introduce Suboxone immediately, they'll go into really severe withdrawal. So you want them to have some withdrawal symptoms before you start. And as I keep saying, buprenorphine, it's very hard to die from that, very, very hard. There's a proportion of people who die on methadone because they combine it with things. You can overcome the safety that methadone provides. It's just a much, much safer alternative.
Thank you. And last question is, what are your thoughts on the rise in medicinal cannabis prescribing?
So first of all, I'm an addiction psychiatrist, and I think all drugs should be legalized. I don't see the advantage of making drugs illegal and then having our gangs shooting each other in the streets and beating up people. And I just don't see that corrupting the police and the rest. I just don't see as a society that works. Look, it's so comical. I used to work in a prison and drugs were entering the prison. Now, and people were becoming psychotic on whatever they were using. So if we can't stop drugs entering the prison, what's the point of banning anything? It's just pointless. So you'll see these headlines, cocaine bust or whatever. It's irrelevant. As you can see, whole countries are being overthrown by crime gangs. I remind patients that when they use cocaine, they're supporting drug cartels which kill and rape and destroy and completely undermine whole governments. And I say, look, you're a nice young lady or a nice young gentleman. How do you feel that your money is going to support somebody who's doing this, who's destroying people's lives, killing innocent people, and so on? The reason I say that is because that's what's going on. But wouldn't it be better if it was all legalized? So I think that prescribed cannabis, I don't like to call it medicinal cannabis because I don't see anything medicinal about it. It's prescribed cannabis. It's a way to move us into legalizing it so that I don't know if you saw that article where there was something like 8,000 prescriptions a day or something by a GP for prescribed cannabis. It's given to people who want to use cannabis, and the people I see are largely cannabis users. So look, there was great hope, and there was the promise that CBD, for example, would cure anxiety and stop people from needing opiates, and also there are all sorts of promises. Unfortunately, hasn't been delivered. Maybe at some time in the future, there'll be specific CBD receptors that will do something really useful, and it's all going to be great. But I've only got maybe one or two patients who use CBD for their anxiety and find it helpful, but not THC. You use THC because you want to be high. That's why you use THC. And it's not a good thing in the sense that the people so now you can get very high concentrations of THC in prescribed cannabis, and it's just cannabis, whether you get it informally at the pub or you pay a doctor and get it at a pharmacy, it's the same deal. It's no different. So, And as I say, I treat ADHD all day. A large number of people are using cannabis. Remember, cannabis is called dope. It makes you dopey. It doesn't do any good. And hardly anyone wants CBD. There's not much of a market for that. It's all the THC that people want.
Yeah. No, thank you for that. And yeah, that's all our questions. So thanks for answering all of those. And sorry we didn't get to go back to finish off your presentation, but thank you so much, Dr. Mistek. And yeah, thank you to everybody tonight too. It was a really engaged group. So yeah, thanks for all your questions and your feedback and comments on everything. And sorry, we have run over time, so I'll let everybody hop off and enjoy the rest of your evening. And just a reminder to complete the evaluation form that should pop up on your screens. Thank you.